Dear Chairman, dear colleagues, good morning. Kalimera. It's a great honor for me to invite it to Hellenic Urologic Association annual meeting. In this section of the meeting, I would like to talk about the new horizons of the surgical treatment of BPH. And in my speech, I want to focus on the disadvantages of the HOLEP technique. I mean, the disadvantages is the misunderstanding, and there are some problems for this HOLEP surgery because some of them they are doing resection, but they are using the name of a HOLEP. HOLEP means enucleation, and there are some disadvantages for the equipments, especially for the morcellation part of the step of the surgery. We need new equipments. You know, there are some goals for the surgical treatment of BPH. We have to provide the continence after the surgery. We have to improve the symptoms of the patients, and during this surgery, we have to preserve the erection. During the open surgery, there's no problem to locate the capsula. You can easily feel with your finger. But during QRP, is it easy to locate the capsula? It's not possible. But during HOLEP, you have to locate the capsula. If you can't be able to locate, you are using a wrong technique. The main problem for HOLEP is there is no proper technique that was published in the literature already. Please remember the techniques in the literature. You'll see B-lobe enucleation, 3-lobe enucleation, and block enucleation. These are the shapes of the prostates. These are not the techniques. These are the shapes of the prostates. And there are some limitations. For example, when you look at these techniques, you see only 5 landmarks. One of them is Verumontano. But the technique must be standard and includes anatomical landmarks. Let's look at this study. If you search the literature, you see only 2 anatomical study articles about the external urethral sphincter. And the omega sign, the omega shape is very important. The end point of the surgery of the HOLEP must be the omega sign. The sphincter seems like an omega sign. You see the pictures of the cadaver. Here you see the omega sign, and you see 3D-dimensional resection of the external urethral sphincter, and the red color is the external urethral sphincter, the yellow is the urethra, and the green is the bladder neck. Can you start the video? Here you see the end point of your surgery must like an omega sign. You'll see the leaf of the tissues like an omega. The behind of these tissues, it's empty. There is no adenoma. And, oops. How can I? And now you see the video of the patients after 3 months. It's like an omega sign. So there is no doubt. HOLEP is the gold standard for the surgical management of BPH in the 21st century. But it's interestingly, you see, according to EAU guidelines, the HOLEP is recommended only for large prostates. But please look at the new literatures, new articles. You see that they concluded that HOLEP is a safe and effective procedure for treating symptoms of BPH independent of prostate size and is associated with low morbidity. The efficiency of HOLEP increases with increasing the prostate size. And I would like to show you the timeline of HOLEP studies. Please look at last 5 years. After 2013, the frequency is increasing for the HOLEP. So, Peter Willing used this topic for his article. HOLEP has come of age. I fully agree with him. HOLEP could now be considered the true gold standard surgical treatment for BPH. HOLEP has come of age. There is no doubt. For large prostates, open and HOLEP surgery, open prostatectomy and HOLEP surgery has a similar results. No coterie effect. Easily diagnosis of any kind of malignancy, and pathologists easily and much more efficiently examine this specimen. And for flow rate, they have similar results. But let's look at the complications rate. According to EAU guidelines, open prostatectomy has a high operative morbidity. And HOLEP, but don't forget, HOLEP is not only an alternative to open prostatectomy, but also alternative to all other transurethral treatment methods. This is the misunderstanding issue. The size of the prostate is not important for the HOLEP. Let's look at this meta-analysis. They investigate, they analyzed the functional outcomes and complications following transurethral procedures for lower urinary tract symptoms resulting from BPH. They compared 2RP, bipolar 2RP, bipolar 2UVP, KTP, and HOLEP. And when they compared HOLEP versus 2RP, they saw that they concluded that Qmax result is higher in HOLEP group, and IPSS score is lower in HOLEP group. And let's look at the complication rates. You see 8.8 for HOLEP. It's very low. And they compared HOLEP versus the other transurethral procedures, and length of stay, catheter time is very low in HOLEP group. Tissue removed is more than the other groups, and change in Qmax is more higher in HOLEP group. And they compared HOLEP and open. Length of stay and catheter time is lower in HOLEP group than open. Tissue removed is similar with open. Transfusion rate and hemoglobin loss is lower compared to open. And what about the reoperation rate? HOLEP has been described as a surgical method of BPH which has lowest reoperation rate in long-term follow-up. But the main difficulties of the HOLEP is the long learning curve, the steep learning curve. For robotic radical prostatectomy, it's known for 25 cases enough, but for HOLEP, actually, for HOLEP, it must be approximately 50 cases. And there is a confusion for HOLEP. What does it mean? HOLEP is meaning holmium enucleation of prostate. So, please look at this video. Oops. Is it enucleation? If you search YouTube, and if you write HOLEP and search the YouTube, you see these kind of videos. These are not the enucleation, these are resection. For enucleation, you have to see the capsula, and you have to use low energy. At the end of the surgery, your total energy must be low. HOLEP surgery is based on the principle of cutting the plane between the prostatic capsula and the adenoma tissue, using the holmium laser and separating the adenoma with blunt dissection. Enucleation is mandatory, enucleation is necessary. HOLEP means enucleation. Now I would like to show you the enucleation. What does it mean? What does I mean? You see the capsula and the adenoma. With the tip of your instrument, you can easily enucleate the adenoma. The tip of the instrument is like your finger. So you see, I'm not using the energy. You can use the energy, the laser energy, only for coagulation and resection and cutting some attachments of the tissues between the capsula and the adenoma. And please look at this study. The total energy, using total energy, is decreasing with the experience. What's the difficulty of the HOLEP? The main difficulty is the morcellation. During the morcellation, some of the adenoma tissue is hard. It's not easy to morcellate this tissue, or it's not easy to remove with the grasper. So the industry must develop some new equipments for this procedure, for this step. Now I would like to share my technique, my new technique for the HOLEP. Sorry. I mentioned to you before, there is no proper technique that was described in the literature. There is no landmarks. There is no strict criteria. There is the techniques described only for B-lobe, 3-lobe, and M-lobe enucleation, but these are the shapes of the prostate. I start, first of all, you have to see the ureter, oral orifices, and then do the incision between the lobes, laterally to median lobes. I'm using 120 watt luminous laser. It has two pedals. One is for coagulation, the other is for resection. For resection, I'm using 100 watt. For coagulation, I'm using 40 watt. You know, holmium laser, during holmium laser, the energy is absorbed by the water. Then it causes explosion, and it works like a blunt dissection, like your finger. When you so you see the other, you see I'm doing the resection, incision to the 12 o'clock area now. First of all, you have to do incision lateral to median lobes, then 12 o'clock area, then between these locations, I mean, do the incision to the mucosa that covering the adenoma, but not like a circular incision. Deeply, this incision to the mucosa must be deep. Then, during enucleation of the medial lobe or lateral lobes, we are using the tip of the instrument to sweep the prostate. You have to use the tip of your instrument for blunt dissection. The moment of these instruments, like the laparoscopy equipments, if you have an experience on laparoscopy, it's easy to do HOLEP. You have to see the capsula and the vessels under the capsula. If you find the proper, correct plane, you will see there's no vascular damage and there's no blood. At the bladder neck area, we are using cutting mode for the resection, for the incision of the tissue. But for the other parts, especially for during the apical dissection of the apical incision of the prostate, I'm using lower energy mode. Here you see we use the energy only for the adhesions of between the capsula and the adenoma. And the energy laser is, we are using the laser for the coagulation only. It's not an easy surgery, but the future is the HOLEP. At the end of this surgery, the end point is you have to see the omega sign. If you see the omega sign, you can sure that the patient has no continence problem, and you can sure that you remove whole of the adenoma. If you want to watch the without videos, without edit videos, you can look at the YouTube. But we will share our new technique videos after publishing our article. Now we finished the right lobe. Now the omega sign. Behind this tissue, there is no adenoma. If you see this picture, this shape, it means that your patient has no continence problem. The main problem is the morcellation part. The industry must develop new techniques, new instruments. We have some studies, some of them was published and others are going on. Prostate shape is very important. If your prostate like a pear, it's easy. If it's like an apple, it's not easy. Patients with a longitudinal rather than an oval-shaped prostate have a shorter HOLEP time with a reduced energy usage, although the postoperative outcomes were similar in both these groups. The role of laparoscopy experience on the learning curve of HOLEP surgery. This study is a questionnaire-based study. The purpose of this study is to demonstrate the impact of laparoscopic experience to the HOLEP learning curve by examining the association between the learning curves of surgeons performing both laparoscopy and HOLEP surgery. And we concluded that laparoscopic experience seems to be beneficial for the surgeon while learning HOLEP. Highly experienced laparoscopic surgeons have a shorter HOLEP learning curve. The other study is the effect of prostatic tissue density on the perioperative outcomes of holmium laser enucleation of prostate. Our aim is to evaluate the effect of prostate tissue density on perioperative outcomes of HOLEP procedure, and we concluded that prostatic tissue density is a factor that influences the HOLEP on perioperative outcomes, and prostatic tissue particularly affects the morcellation phase of the surgery, and patients with higher prostatic tissue density will have a longer duration of morcellation, and future studies will, with the use of different imaging methods, will give insight into the duration and difficulty of the HOLEP. The other study is the lower effect of holmium laser enucleation of prostate, a comparative study. Our aim was the proper energy selection during the different steps of the procedure has always been a matter of debate. In this work, we compared the effectiveness of the holmium laser using two different lower energy settings during enucleation and hemostasis, and we concluded that the new 120 watt holmium laser can be used efficiently utilizing the 100 to 40, approximately 40 watt settings. With the use of approximately 40 watt, both enucleation and hemostasis can be performed successfully, while the use of 100 watt in the bladder neck shortens the duration of the procedure. The other study is the comparison of efficiency of HOLEP below 80 gram and above 80 gram. Our aim was to evaluate the effects of holmium laser enucleation of different prostate size. So, as a conclusion, HOLEP is an effective treatment method for a small prostate as well as large prostate. As a urologist, as a surgeons, we have to focus on new technologies, and we have to give happiness to our patients. Thank you very much.
Thank you very much, Professor Tunc.